Hello, Dr. Debbie Morris here, and we are starting a new module today. We're going to talk about the physiology of the kidneys. I have only 2 lectures in this module. The second one includes a couple of cases. So this first lecture is pretty long and pretty detailed, and I may have to divide it into 2 different videos. We'll see how it goes as I record. As we go through the kidney, it's a little bit like that old movie, was it Fantastic Journey? You can kind of imagine we're in a submarine and following the course of the fluid that starts in our plasma and ends up in our bladder. And when we get there, we'll start to talk about kind of in order exactly what happens in the kidney. So during today's lecture, we're going to do a number of things. We're going to talk about the function of the kidneys and in some detail about the anatomy of the kidney, because understanding the anatomy of the kidney is helpful in following the physiology. We're going to talk a lot about pressures. We talked about pressures in the cardiovascular system. We talked about pressures in the respiratory system, but we're going to talk about pressures again in the kidneys because there are some very interesting mechanisms that govern the movement of fluid through the kidney structures and govern the blood flow through the kidney structures. There are 3 major processes that occur in the kidney, and we'll talk about where and how they occur as we take our little submarine and move through the tubules that make up the nephron of the kidney. So I'm going to start with just a little bit of review all the way back to the first lecture. We have homeostatic mechanisms that maintain very tight control of the concentration of lots of substances in our blood, but we're going to be talking here about electrolytes. Particularly as regards the kidney, we're going to think about sodium and potassium and calcium and their concentrations in mainly extracellular fluid, but remembering that we have these mechanisms to maintain very tight concentrations both in the intracellular and in the extracellular fluids. If we don't have exactly the right amount of these electrolytes, things quit working. And in the course of a normal day, we take in more sodium, more potassium, and more water than we actually need to maintain balance. And so the kidney is important in eliminating the excesses of these substances, but also responding when these substances are low. Another function of the kidneys is that it eliminates some of the metabolic waste products. And the one that we most often think of is a nitrogen compound called urea that is left over after protein metabolism. If urea builds up, it can become toxic. Urea as a nitrogen containing compound can become converted to ammonia, which is also very toxic. And the kidneys are important in making sure that urea is eliminated. What is the waste product of glucose metabolism if urea is a waste product of protein metabolism? The main waste product of glucose metabolism is carbon dioxide. And we've already talked about where carbon dioxide is eliminated, right? Carbon dioxide is eliminated through the pulmonary system, through the lungs. Another function of the kidneys that we often don't think about is that it is an endocrine organ. It makes hormones. We've already talked a bit about the kidney as the endocrine organ that makes the hormone renin. And we'll talk a whole lot more about renin before the end of this module. But the kidneys also make a growth factor for red blood cell production called erythropoietin, which is a hormone because it is made in the kidneys and then transmitted through the bloodstream to the bone marrow, where it acts on the precursors for red blood cells. And the kidneys activate vitamin D into the hormone 1,25-dihydroxycholecalciferol. Say that 3 times fast. In addition, along with the liver, the kidneys are able to engage in the production of glucose from non-carbohydrate substrate. So some lipids and some amino acids can be turned into glucose. That's primarily done in the liver when sugars are low and glucose is required, but it can also be accomplished in the kidneys. Just as the lungs are important in the regulation of pH, of the acidity of the blood, and the extracellular fluid, in the kidney also is extremely important in pH regulation and acid-base balance. And we will have another lecture on acid-base balance. The kidney is important in regulating osmolality, the basically concentration of solute in the extracellular fluid, and if it's in the extracellular fluid, also in the intracellular fluid. And through a number of mechanisms, including how the kidneys handle water and electrolytes, and through its endocrine function in producing renin, the kidneys are extremely involved in the regulation of the volume of extracellular fluid and of blood pressure. So let's look at anatomy. This is a diagram, a drawing of a sagittal section of the kidney. So this kidney has been sliced from top to bottom, and you can see some things about this structure. The kidney is covered with a fibrous capsule, which I don't think is labeled on this diagram. So there's a fibrous covering on the outside. Immediately under the capsule is the cortex, and within the cortex is the medulla. The cortex has something called medullary rays are in the medulla. I'm not sure why it's showing that, but medullary rays are these linear structures that are extending down through the pyramids of the medulla towards the papillae, where the urine is discharged into the renal pelvis at something called calyces. So there are minor and major calyces. The renal pelvis then is the structure through which urine collects and enters the ureter, and from there goes to the bladder and eventually is eliminated to the outside. The extensions of cortex between the pyramids are called renal columns. And I want to talk a little bit about the blood supply of the kidneys. For each kidney, there is a single renal artery and a single renal vein. The renal artery is a direct branch of the aorta. The renal veins join the inferior vena cava. The renal artery branches and branches into the capillaries that form the glomeruli that are primarily in the renal cortex. And we'll come back to that. So in this diagram, again, we're looking at least part of a sagittal section. We're also looking at a horizontal or axial section. you can see the suprarenal gland or adrenal gland in its spot sitting as a little cap on top of the kidney. And we will talk about the adrenal gland when we talk about endocrinology. But for now, it's sitting there on top of the kidney. You can see, as I mentioned, that there is a single renal artery and a single renal vein. That renal artery divides and divides and divides. And here we are showing those divisions into arterioles that then ultimately feed the glomeruli and form the capillary structure of the glomerulus. The glomerulus has two sets of tubes. It has capillaries that are fed by arterioles. It also has tubules that begin with Bowman's capsule and collect the filtrate and process the filtrate into urine, which is eventually eliminated. There are straight arterial branches called arterioli recti renus. So that, recti means straight. Renus has to do with kidneys, and there are similarly straight venules, and these are called the vasa recta, and they're part of the renal pyramid. And you can see here how the glomeruli are in the cortex of the kidney, but the tubules and the venules and arterioles, the veni, the vasa recta, are what composes the medullary part of the renal papilla. And here's an actual pathologic, normal specimen, but a kidney that has been sliced sagittally. We are not seeing a lot about the vessels here. We are seeing the renal pelvis. We are seeing the capsule, this whitish grayish covering, the cortex, the medulla with the pyramids. The pyramids contain the vasa recti and the nephron, the collecting tubules, the tubule part of the nephron, while the glomerulus, which is part of the nephron, is sitting here in the cortex. And then as the papillae of the pyramids discharge their fluid, their urine, into the renal pelvis, from which it enters the ureter. The kidney is retroperitoneal, so it is not within the abdominal cavity with our other abdominal organs. It is behind the peritoneum, in the abdomen, or behind the abdomen, quite near the vertebra where the thoracic vertebra join the lumbar vertebra, which we call the costovertebral angle, because costo is rib, right? And we have ribs on our thoracic vertebra. And that angle where the lowest rib intersects with the spine is this junction where the kidney is sitting sort of just in front of that, in front of muscle and spine, but behind the abdominal cavity. The capsule is a very fibrous material, and under the capsule is the cortex. As I said, that each kidney has one renal artery that is a branch of the abdominal aorta. Each kidney ultimately joins into a single vein, the renal vein that enters the vena cava, and then that third tube, the ureter, emerges from the center of the kidney at the renal pelvis and takes the urine to the bladder. And here we can see some indications of the location of the kidneys. So this is a frontal view. We're looking at the frontal view, and we can see the kidneys sitting relatively posteriorly, which you can see on this cross section, axial section, that if this is the guts and this is the peritoneum, here's the stomach, here's the pancreas, which is also retroperitoneal. Kidney is sitting here lateral to the pancreas, lateral to the spinal column, anterior to the lumbar muscles, and at about the thoracolumbar junction. This is a view of a plain radiograph x-ray that is called a KUB, a kidney ureter bladder, and it is also called a flat plate, and it's a view that's taken with the patient lying face up on the table with the plate that's going to be detecting the radiation behind under their back, and the tube above them projecting from front to back. So we're kind of looking down on a belly here, and this includes both the pelvis and the abdominal cavity. We need to be able to see the symphysis pubis, and we need to be able to see the diaphragms. And the kidneys cast shadows that you actually can sort of see. There are a lot of overlying shadows on this sort of an x-ray, and it's usually easier to see the right kidney. So here we can see the right kidney, and here we have it outlined. The kidney is kind of sitting under the liver, which overlaps it a little bit. The spleen is way up here. You can't really see that on x-ray, and I always find it kind of hard to see the left kidney. I think they're imagining this outline. You often can see a shadow of the psoas muscle, and that's what these lines called P are. And you may or may not be able to see the fluid in the urinary bladder. Again, there are intestines, and within the intestines are stool and gas, and all of that can sometimes obscure the kidneys and ureter and bladder. But if you know that this is the right renal pelvis, and that the ureter comes down and travels sort of alongside the vertebra until it enters the bladder, sometimes this is a view on which we can see radio-opaque kidney stones. Occasionally you can see evidence of a swollen kidney. Again, let's go back to that very first lecture and talk a little bit about body fluid distribution, because as I said, the kidneys are really important in maintaining homeostasis of fluid and electrolytes. So if about 60% of the body weight is water, and we can think of it as 2/3 just to be simple, and that's variable depending on muscle mass, age, so it's lower in women and lower in people who are very fatty. This water that is about 2/3 of the body weight is distributed between compartments, and those compartments we have labeled as the intracellular and the extracellular compartments, and about 2/3 of the water is in the intracellular compartment, so it's sitting inside of cells, but about 1/3 of it is extracellular. We can further subdivide the extracellular compartment into interstitial, which is all the fluid around cells but not in them, in the tissues, and intravascular, which is the water that's inside of the blood vessels. And this is the water component of plasma, which is composed of water and electrolytes, but also of a number of plasma proteins. The fluid we call plasma, which is, if we take blood and spin it and discard the cells, what's left, the clear supernatant, is this very slightly viscous, very proteinaceous fluid called plasma. The fluid inside the vessels, the plasma, has lots of protein, but the fluid in the interstitial compartment doesn't. It's an ultrafiltrate. It has to be able to cross all those cell walls and capillary membranes and whatnot, and it does not have a lot of protein in it. Again, going back to that first lecture, I want to review the concept of osmolality. So remembering that while osmolality and osmolarity are slightly different, they're different in definition. They are functionally very similar, and we can measure osmolality, and so we tend to refer to serum osmolarity. So it's for osmolality. I do it every time. Um, Osmolality, by definition, is the concentration of osmotically active particles. So this is molecules or ions, and it's not their weight, it's their number in a mass of water. So it's usually expressed as milliosmoles per kilogram. And as you know, a kilogram of water is a liter of water, but because of how the solute for liter is measured, there are slight differences if you get to high values. At the values we're talking about in living organisms, they're almost exactly the same. Now, the volume in a given compartment is dependent on the amount of solute in the water, and that solute is primarily certain electrolytes, including sodium and its anions, chloride and bicarb, and then the small molecules, glucose and urea. And urea is often called blood urea nitrogen, or BUN, or BUN. And all of these things can be measured. So we can send blood to the lab and determine the concentration of sodium, chloride, bicarb, glucose, and urea. We can't measure what's going on inside of cells. You remember that. And cell membranes are semi-permeable membranes, and osmolality in all of the compartments is maintained at the same level by the movement of water, which is osmosis, across those semi-permeable cell membranes. Now, there's an additional component to plasma that I mentioned, which is the proteins in the plasma, and these include albumin, which is the most common protein, and then a number of proteins that are involved in the clotting of blood, so clotting proteins, and also the regulation of clotting, so they're kind of anti-clotting proteins. And there are proteins that are made by the immune system that we call globulins or antibodies. So all of those proteins dissolved in the plasma create a pressure that we call colloid osmotic pressure. And you can think of it like this. It's not the same as osmolality, but it has a similar effect. The protein in plasma in the vessels exerts a pressure because it decreases the volume of water in those vessels. Since there's protein, there's less water, and so water is going to be pulled out of the interstitium into the vessels by this colloid osmotic pressure, which can be expressed in millimeters of mercury. And we talked about that a little bit in cardiovascular. You remember that I said that one of the forces that or one of the pathologies that can result in edema is low plasma proteins. If we don't have proteins in the plasma, then fluid tends to stay in the interstitium. It doesn't get pulled back in, and that creates edema. And that can happen when the liver is unable to make adequate proteins, for instance, in chronic liver disease, cirrhosis. It can also happen when the kidneys are unable to keep proteins like albumin in the plasma. So normally proteins stay in the plasma and don't filter out through the urine, but a damaged kidney can get leaky. And if you're losing a good deal of protein, you can get edematous too. Different diseases, different conditions do different things to fluid balance. And I want to talk just a little bit about some of the disturbances in fluid balance, and we'll be coming back to this. But if you consider the osmolarity of blood and interstitial fluid and intracellular fluid, it's all the same, right? But if you do something to decrease extracellular fluid volume, for instance, diarrhea, you have severe diarrhea, you're losing fluid from the extracellular compartment. Same thing with burns. The fluid that you're losing has a similar osmolality to the fluid that you keep. And because of that, your extracellular volume goes down, but your intracellular volume doesn't change because the osmolality hasn't changed. And hematocrit goes up because part of the extracellular fluid compartment is the intravascular compartment, and you're losing fluid out of that, but you're not losing cells. And the same is true of plasma proteins. They're going to go up. Sometimes we lose fluid that is actually less concentrated. You lose more water than salt, okay? And you become hyperosmotic. So the volume contracts because of the loss of water in excess of salt. And some things that do that are sweating and fever, and the condition we call diabetes insipidus, which is the lack of a hormone that we've talked about, antidiuretic hormone, ADH. So if you can't make ADH, you lose tons of water. And that's called diabetes insipidus. And in this case, your extracellular volume goes down, but because you're losing water in excess of salt, your osmolality goes up, and therefore fluid is going to be moving, water is going to move out of the intracellular compartment into the extracellular compartment to try to equilibrate this loss. You won't have much of a change in hematocrit. On the other hand, if you lose salt in excess of water, and this is something that can happen in adrenal insufficiency, if we don't have enough of a hormone called aldosterone that we've touched on, the kidneys waste salt. Kidneys waste salt. And we have a decrease in extracellular volume, a decrease in osmolarity, and therefore water is going to be moving out of the extracellular compartment into the intracellular compartment. Now, similarly, if we give somebody isotonic sodium chloride, which is 0.9% sodium chloride, isotonic means that it's essentially at the same osmolality as blood. So if we give somebody isotonic sodium chloride solution, normal saline, we increase their extracellular volume, but we don't have fluid moving either into or out of the intracellular compartment, and we won't have a change in osmolarity. If we have somebody either we administer hypertonic sodium chloride, so say sodium chloride that's 3% instead of 0.9%, or if we have a patient who takes in so much additional salt that their kidneys aren't able to eliminate it immediately easily, then that salt makes them hold on to water. Their extracellular volume goes up. It is a little hypertonic, so it pulls fluid out of the intracellular compartment because the extracellular osmolality is high. And then finally, the syndrome of inappropriate ADH. If you make excess ADH, or antidiuretic hormone, which happens sometimes after head injuries, sometimes with certain tumors, particularly small cell lung tumors, but other tumors as well, can produce an ADH-like substance that acts as ADH in the kidneys, preventing the loss of water, basically making us hold on to a lot of water but not salt, because ADH acts in a part of the kidney where salt and water are handled differently. So we have volume go up, osmolarity go down, and we're going to see the movement of fluid out of the extracellular into the intracellular, because the osmolarity in the intracellular is higher than in the extracellular. Let's move on to the kidneys. I want to talk about the blood supply of the kidneys. That single renal artery, which is relatively close to the heart, has high pressures, very close to normal systolic and diastolic blood pressure, systemic blood pressure. And those arteries branch and branch and branch into about 1 million arterioles, which then become a tuft of capillaries that's called the glomerulus. So here we have an artery branching into an arteriole and into this little tuft of capillaries that is called the glomerulus. You can see that there are 2 arterioles. There is one entering the glomerulus, which is called the afferent arteriole. It's going to. And there is one leaving the glomerulus, this tuft of capillaries, and that is called the efferent arteriole. And it then branches again into a network of capillaries that surround the tubules of the nephron. If you remember from the cardiovascular lecture, I said that arterioles are the main source of peripheral vascular resistance, and that there are mechanisms that allow arterioles to dilate and constrict, and that dilation and constriction at the level of the arterioles changes the pressure in the capillary beds. In the glomerulus, it's a little bit more complicated because we have both an afferent and an efferent arteriole, which are separately controlled. And so one of them can constrict when another dilates, and different things that happen to these 2 arterioles affect the pressure in the glomerulus. For instance, if you imagine if the efferent arteriole stays the same, but the afferent arteriole dilates, then higher pressures are going to be transmitted into the glomerulus. If the afferent arteriole constricts, lower pressures. If the efferent arteriole dilates, then lower pressures, because more blood is easily able to flow through. If the efferent arteriole constricts, then higher pressures. And they're being acted upon by different things at the same time to create the proper amount of resistance and pressure in the glomerulus. And we'll talk about why in a couple of minutes. But blood flow and pressure in the glomerulus is controlled by the dilation and constriction of the afferent and efferent arterioles. Now, lots of things are being carried in the blood to the kidney. And among the things whose concentration is regulated by the kidney are sodium and potassium, water, and urea, and then certain other substances, calcium ions, phosphate ions, and all of those are regulated by the kidney, carried to the kidney in the blood. There are other substances in the blood, some smaller and some larger molecules, that make it to the kidney. And some of them make it through the glomerulus into the filtrate. In any given moment, somewhere between a fifth and a quarter of the cardiac output is going through the kidneys. So if cardiac output is about 5 liters a minute, more or less a liter a minute of blood is flowing through the kidneys. And the plasma that enters each of those million glomerular capillaries, each of those little tufts of capillaries that makes part of a glomerulus, that plasma is filtered across the capillary wall. I will come back to this, but you remember that some capillaries are fenestrated. They have little holes in them, and the capillaries and glomeruli are fenestrated capillaries. And so you can kind of imagine them as little sieves, and the plasma that is coming through the tuft of glomeruli, some of the fluid in that plasma is being pushed out of the wall of the capillary. Big things like big proteins stay in the capillary, cells stay in the capillary, but part of the water and the electrolytes and other things that are dissolved in the water enter the space around the capillaries that is called Bowman's space. So the tuft of capillaries is sitting in a space that is bound by a membrane. That space is called Bowman's space, and there's very low pressure in Bowman's space, but there is pressure in the capillaries, and so the pressure in the capillaries pushes fluid, filtrate, out of the capillary, out of the vessel, and into this low pressure Bowman's space. And here I have a micrograph and a diagram comparing, showing you this space. So this is a single glomerulus. Within the glomerulus are a number of capillaries, and you can see the red cells in the capillaries. There are also some cells. There is a membrane lining this space called Bowman's space. And the cells within and around these capillaries have different functions. There are cells called mesangial cells. There are cells called podocytes, and the podocytes surround these fenestrated glomerular capillaries. There is an afferent arteriole entering and branching into the tuft of capillaries we call the glomerulus, and there is an arteriole because no oxygen is being lost here. So it continues to be an arteriole carrying oxygenated blood, but an efferent arteriole leaving the glomerulus. And then the space we call Bowman's space is continuous with a tubule, a skinny little tube that is lined by cells, and we'll talk a lot about those cells as we move through our little fantastic journey. So here in the micrograph you can see the red cells in the capillaries, you can see the nuclei of the podocytes, Maybe these are mesangial cells because they don't seem to be quite as associated with capillaries as these ones do. And I don't think we see very easily the tubule leaving here. I won't go into a whole lot of detail about this, but a glomerulus is part of a structure called a nephron, and a nephron consists of the glomerulus and its tubule. And each nephron could be considered a functional unit of the kidney. And if there are 100 glomerular capillary tufts from those, 100, a million, from the million branches of the renal arteries, about 500,000 to each kidney, then there are about a million nephrons. There are essentially two types of nephrons. We talked about how the glomerulus is sitting primarily in the renal cortex and how the vasa recti and the tubules descend into the medulla, into the pyramids. There are glomeruli that have very long tubules descending deep into the pyramids that are called juxtamedullary glomeruli. Nephrons, sorry. It's a juxtamedullary glomerulus and a extra long loop of Henle. Okay, and this makes up only about 15% of nephrons. The majority of nephrons are these shorter, somewhat less complex nephrons that do not descend as deep into the renal medulla. I mentioned a couple things about the glomerular capillary that are illustrated here. One is that they are fenestrated capillaries. They have lots of little holes in them. They're essentially a very, very, very fine strainer, allowing fluid to pass across the capillary walls. They are surrounded by these cells called podocytes that have many, many feet that are lining the outside of the capillary wall. And they serve an important function. They are involved in preventing charged substances like proteins from getting across this fenestrated capillary wall. Let's see if there's anything else we need to look at here. So you can see the capillary is a fenestrated capillary. It has podocytes. Outside of that capillary is Bowman's space, the urinary space. Same thing here. We have these podocyte processes on the capillary. This is the inside of the capillary with its fenestrated wall, and outside of that capillary is the urinary space where the filtrate collects. So, from the renal artery to segmental arteries to interlobar arteries to arcuate arteries to cortical radiate arteries, which are part of the vasa recta, to afferent arterioles, to the tuft of capillaries we call the glomerulus, to the efferent arteriole, and then to capillaries that surround the tubules of the nephron, and then to venules, to cortical radiate veins, which are the vasa recti, to arcuate veins, to interlobar veins, to the renal vein. Now, I mentioned that the pressures and the constriction and dilation of the afferent and efferent arterioles are separately controlled. And there is something called glomerular filtration rate, or GFR. So the filtration rate, how quickly fluid can filter out of the glomerulus into the urinary space is dependent on the pressure in the glomerulus, which is dependent on the diameters of the afferent and efferent arterioles, which are separately controlled. And that's illustrated here. So we have an afferent arteriole, and there are things that can make it dilate. Among those things are prostaglandins, kinins, dopamine, and this is dopamine given as a drip, and this is dopamine in low doses, something called atrial natriuretic protein, which is produced by the cardiac muscle in the atrium in response to high levels of volume and nitrous oxide. If we dilate the afferent arteriole, it increases pressure in the glomerulus and glomerular filtration rate goes up. But similarly, if we constrict the efferent arteriole, and low doses of angiotensin II do that, then we will get increased pressure in the glomerulus because there's resistance, so pressure is higher, and again we'll get increased GFR. On the opposite side, if we constrict the afferent arteriole, which high doses of angiotensin II do, also noradrenaline, sympathetic nerve discharge, other substances, something called endothelium, ADH, antidiuretic hormone, and things that block prostaglandins. And I'm going to say that it's important in medicine to understand this. Can you think of anything that you know of that is a prostaglandin blocker? The drugs that we call NSAIDs, nonsteroidal anti-inflammatory agents like Motrin, are blockers of prostaglandin, also aspirin. But Motrin and which is ibuprofen, and Aleve, which is naproxen. These are prostaglandin blockers. They cause afferent arterial constriction, decreasing the pressure in the glomerulus and decreasing glomerular filtration rate. On the other hand, if we block angiotensin II, and there are drugs, right, that block angiotensin II, like ACE inhibitors, we dilate the efferent arteriole, again decreasing pressure in the glomerulus and decreasing GFR. This is an important slide to understand, and I want you to kind of talk yourself through it until you get it. So the afferent arterioles bring the blood in to the glomerulus where it's filtered. The efferent arterioles take the blood out of the glomerulus and deliver it to the capillaries around the tubules. And that's really important because a lot happens in the tubules and we have to reabsorb things out of the filtrate. We also sometimes secrete stuff back out of the blood into the filtrate in the tubules. So we need capillaries surrounding those tubules. And both the afferent and efferent arterioles, separately controlled, participate in establishing the pressure in the glomerulus and that tuft of capillaries and blood flow through the glomerulus. Let's talk about the three processes that tend to occur in the kidneys. The first is filtration, and filtration is what I'm talking about in the glomerulus, where fluid and things in the fluid get pushed through the little sieve that we see as the wall of a fenestrated capillary past the podocytes, if they can get past the podocytes and into the urinary space. That's filtration. As that fluid proceeds through the tubules, almost everything that was filtered gets reabsorbed, and it's a very precise and selective process. And this is important because we are if we didn't reabsorb, we would die of dehydration in hours. We are constantly moving fluid out of the vasculature into the urinary space, and we have to get a lot of it back along with certain other things. And then it is possible at different points along the tubule for substances to be moved out of the blood into the urine, and that can include electrolytes, it can include hydrogen ions, and we'll talk about those as we go through. And this is just a slide that is showing you these processes, although excretion here is referring to the urine being made and excreted, but there is secretion, sometimes called excretion, which is separate from this. But here we're showing a tubule lined by cells that are called tubular cells. The tubular cells have two sides. They have a base which is more or less in contact with the peritubular capillary, obviously interstitial fluid between them. There is an apical side which has a large surface area. The material that is filtered comes into the lumen of the tubule. Substances can be reabsorbed in different ways. They can be reabsorbed by activities that take them through the cell. In some cases, they are reabsorbed between the cells, and that's called the paracellular path. They can diffuse. They can move by osmosis. So lots of what ends up in the lumen of the tubule from filtration through the fenestrated capillary gets back into the blood through reabsorption. So filtration and reabsorption. What I call secretion in the previous slide is that there are actually some substances that are going to be moved back out of the blood and into the lumen. There are proteoglycans, these substances that are partly carbohydrate and partly protein, in the podocyte extensions and in the basement membrane of the capillaries, and they're negatively charged. And so that negative charge repels large negatively charged molecules like amino acids and proteins. And albumin is small enough that it could make it across the fenestrated membrane, but if the podocytes and the basement membrane are intact and properly negatively charged, it doesn't, or very little of it does. The chloride ions are so small that chloride moves freely in spite of the negative charges. So what ends up in the filtrate? There's a lot of water. There are electrolytes and minerals and ions like hydrogen ions. There are small molecules that are not charged, like urea and glucose and bilirubin. There should be no cells, and there should be minimal proteins and amino acids. Sometimes a little bit of that makes it across. Before we end this segment of this lecture, I want to talk about a concept called glomerular filtration rate, which was mentioned on a previous slide. So glomerular filtration is the movement of fluid out of the capillary into the urinary space. Glomerular filtration rate is the volume of fluid that filters into the capsule, into the urinary space over a unit of time. And in normal kidneys, about 125 milliliters per minute leaves the blood flow and enters Bowman's capsule. And if we multiplied that out, it's 180 liters a day. And so it has to be reabsorbed. Most of it is reabsorbed, and we end up urinating, 500 to 1500, 500 to 1000 mLs a day. So most of the filtrate is reabsorbed. And we can calculate glomerular filtration rate and use it to estimate kidney function. If we alter the filtration rate by, for instance, changing the diameter of the afferent or the efferent arteriole in the glomeruli, then we change glomerular filtration rate. So this is actually a dynamic thing. It is not a static figure. So whenever we alter the hydrostatic pressure, the blood pressure in the glomerular capillary tuft, we alter the amount of fluid that gets filtered. And we alter that by changing the resistance, the diameter of either the afferent or the efferent arteriole. And again, if we increase resistance on the afferent arteriole, we constrict the afferent arteriole, we decrease pressure in the glomerulus, and that decreases filtration rate. If we increase resistance in the efferent arteriole, we increase pressure in the glomerulus and we increase filtration rate. So here we are looking at glomerular function, which is dependent on the filtration pressure and something called the filtration coefficient. The filtration pressure results from the forces that favor filtration with subtracting forces that oppose filtration. So what do we mean by that? What are the forces that favor filtration? Okay, what are the forces that favor filtration? The primary force that favors filtration is the blood pressure in the glomerular tuft. And here we have that as 50 millimeters of mercury. They're adding in the colloid osmotic pressure in Bowman's space, but there shouldn't be any because we don't get much in the way of proteins in this urinary space, so that's 0. The forces that oppose filtration are 2. One is the hydrostatic pressure that is within the Bowman's space, and here we have that as 10. But we also have another pressure, which is the colloid oncotic pressure, which is basically pulling. It's a pressure that pulls back into the vascular space. In this diagram, we have the colloid pressure as 25 and the hydrostatic pressure in the capsule as 15. So these are the forces opposing filtration, and the glomerular hydrostatic pressure as 50. Even though these numbers are a little different, they add up to the same thing. So we have a net filtration pressure of 50, which is the capillary blood pressure, minus 40, which is adding the colloid oncotic pressure that's pulling, and the hydrostatic pressure in here that's pushing. So it would be moving back in that direction. And we have a net filtration pressure of 10 millimeters of mercury that is now projecting the filtrate down the tubule. The filtration coefficient has to do with the permeability of this membrane, which is the capillary wall with its other structures, and the total surface area of the filtering membrane. So if we do something that alters the permeability of the filtering membrane, that can change the filtration coefficient and glomerular function. If we lose nephrons, if we lose glomeruli and decrease the total surface area of the filtering membrane, that can also reduce the filtration coefficient and reduce glomerular filtration rate. So here again, this is just slightly different numbers, and I want you to understand this formula. I will not ask you to do a lot of math in this course. This is one of the places where I will. If you are trying to figure out filtration pressure in the glomerulus, you take your glomerular hydrostatic pressure, which is variable, right? Because it depends on the resistance of the afferent and efferent arterioles. So if we establish that as 60, then we have to take that and subtract two things. The pressure in Bowman's capsule, which opposes filtration, and the colloid oncotic pressure that opposes filtration. So the Bowman capsule pressure is sort of pushing back towards the capillary, and the colloid oncotic pressure is pulling in towards the capillary. So if we add 16 and 34, we get 50. If we subtract 50 from 60, we get 10. And so the pressure, the filtration pressure, is positive 10 millimeters of mercury, favoring filtration. So similar slide, right? But here we are going into a little bit more detail about things that change the filtration coefficient. If you can change the permeability of the filtering membrane by thickening the basement membrane, which happens in a number of diseases, including diabetes and hypertension, we can get rid of nephrons, decreasing the surface area of the filtering membrane by destroying them. So chronic infection can destroy nephrons, chronic inflammation can destroy nephrons. And if these things happen, whatever's going on over here becomes irrelevant, because if you reduce your filtration coefficient, ultimately you will end up in renal failure, the inability to appropriately filter the plasma. And we will talk a lot about reabsorption as we move forward. So I'm going to stop now and divide this into two parts.